good afternoon, everybody, and thanks to the college for the opportunity to present the results of the FLAME study, outcomes in high-risk PE patients undergoing FlowTriever mechanical thrombectomy. These are my disclosures, and pertinently, Inari Medical was the funder and sponsor of the FLAME study. Okay, so it's really quite sobering to all of us in the field, including myself, that in the year 2023, the mortality in high-risk PE remains greater than 25%. And what's even more remarkable is that number is unchanged over the past 20 years, unchanged. Now, we know that the mortality is driven by right heart failure, and it's these acute elevations in right ventricular afterload from the clot burden that is not well tolerated from the very thin-walled right ventricle, and RV failure is what leads to this obstructive shock death spiral that we see in these high-risk patients. Now, I think you're all familiar with the treatment guidelines for high-risk PE, but really they're based on very limited data. Systemic lysis is the recommended frontline treatment, but we know there's associated bleeding risk, 9.2% major bleeding, 1.5% intracranial hemorrhage, and these rates are actually higher in this high-risk group of pulmonary embolus patients. And the reality check is less than 30% of high-risk patients actually receive systemic lysis per the guidelines, and that's because of thrombolytic contraindications and medical comorbidities. So now the rationale for the FLAME study. We know that there's actually very limited data in this high-risk group of patients, and certainly a traditional RCT, which we know is the gold standard, would be very difficult to enroll in. These patients, it's a low incidence, 5% of all PE, it's an emergent presentation, and there'll likely be a high rate of crossover, which would make an RCT very difficult. So FLAME was designed on purpose to evaluate outcomes in these high-risk patients with a large bore mechanical thrombectomy catheter versus or compared to all other non-FlowTriever treatments, any other contemporary therapy. Designed again purposely as a non-randomized study with a pre-specified performance goal that we derived from a very robust meta-analysis that we published a few months ago. And this is what was suggested by an AHA scientific statement to generate evidence in this high-risk group of patients. Again, the trial design, multi-center, prospective, non-randomized, parallel group, basically observational study. Treatment was not dictated to the prescribing physician. Concurrent, non-randomized treatment. Patients were followed through discharge and out to 45 days if necessary. And again, it was designed to capture all high-risk patients, so informed consent was waived, so there would be no bias in enrollment, and a very comprehensive chart review was made to ensure no high-risk patients were missed. The treatment groups, again, were the FlowTriever arm, which was the primary treatment in that arm, the context arm, which again was any other contemporary therapy except FlowTriever, and then a prior therapy arm, which were lower risk patients that advanced to high risk PE and then were put in the study. The inclusion criteria, age greater than 18, had to have a high risk PE, that had to be the cause of shock, the usual blood pressure parameters, resuscitation after cardiac arrest if it was less than 30 minutes and the patient still had good neurologic function. Exclusion criteria was out of hospital cardiac arrest with poor neurologic function, cardiac arrest with CPR greater than 30 minutes, any contraindication to those medicines that we commonly use for PE patients. The rest were usual sort of exclusion criteria. Now, the primary endpoint was an in-hospital composite of all-cause mortality, bailout to an alternate thrombus removal strategy, clinical deterioration, and major bleeding. Secondary endpoints included safety, which were the primary endpoint components, in addition, stroke, device-related complications, and access site injury. The utility measures were hospital and ICU stays, ECMO use, time to extubation, and discharge location. Now again, the endpoint analysis was driven by a comparison to a performance goal which we established by a meta-analysis, which was 32%. There was a pre-specified interim analysis planned at 50 patients, and in fact, FLAME was stopped early because we met that pre-specified interim analysis at 50 FlowTriever patients, where The incidence of the primary endpoint was 17% in the FlowTriever arm, and it hit over 30% in the other arm. So baseline characteristics were basically well balanced, with the exclusion of more DVT and active cancer patients in the FlowTriever arm, and obviously many more patients with contraindications to thrombolytics in the FlowTriever arm compared to the context arm. Clinical presentation was driven mostly by blood pressure parameters. Resuscitation after cardiac arrest with adequate neurologic function was about 20% in FlowTriever, 32% incidence in the context arm. When we looked at sky shock stages, particularly D and E, there was more in the context arm when we compared it to the FlowTriever arm, but importantly, in the patients in the FlowTriever arm with advanced levels of shock, there was 0% mortality. In patients in the context arm with advanced shock, the mortality was 46%. Big difference. PE location was well distributed. Primary treatments, obviously the FlowTriever group received FlowTriever. Estimated blood loss was about 100 cc's. With a FlowSaver device, it was cut in half to 50 cc's. In the context arm, as expected, the majority of patients received systemic lytics, followed by anticoagulation, CDT, and surgical thrombectomy. Now here I'm really happy to report primary endpoint in the FlowTriever arm was 17%, significantly lower than the performance goal of 32%, which we published. The context arm patients, the composite primary endpoint was achieved in 64% of patients, significantly higher than the performance goal of 32%. This is very interesting. In-hospital mortality, when we teased it out from the composite, 1.9% in FlowTriever, 28.5% was predicted by the performance goal. The context arm hit 29.5%. Bailout, 3.8% with FlowTriever. The prediction was about 30%. It was 26% in the context arm. When we look at clinical deterioration, FlowTriever and the performance goal were very similar at 15%, 21% clinical deterioration in the context arm. Likewise, with major bleeding, FlowTriever and performance goal were similar, a little more major bleeding in the context arm, nearly 25%. Safety outcomes, when we looked at stroke, there was 1 ischemic stroke in the FlowTriever arm, 4 strokes in the context arm, 2 of them were hemorrhagic. Device-related complications, slightly more in the FlowTriever compared to context. That was driven by blood loss from the aspiration during the procedure. There was actually no difference in access site complications and actually slightly more hypotension in the context arm. Keeping in mind this is a large bore device, there were no reports of device-related tricuspid valve injuries, cardiac injuries, or pulmonary vascular injuries. In the context arm, 4.8% of patients that received systemic lytics had an intracranial hemorrhage. Other safety things, again, FlowTriever, when we compared it relative to context, trend towards less subjects with SAEs related to the primary treatment device, certainly nothing related to thrombolytic therapy, less ECMO use in the FlowTriever arm, access site injuries, 4 in the FlowTriever arm, 5 in the context arm. Secondary endpoints, again, a trend towards less length of stay post-treatment, length of stay in the ICU post-treatment, ECMO use was less, time to extubation was less with FlowTriever. More patients were discharged to home in the FlowTriever arm, and certainly you saw the mortality numbers. Many more patients expired prior to discharge in the context arm. So this is the largest interventional trial in high-risk PE patients. Large bore mechanical thrombectomy with FlowTriever was definitely associated with a significantly lower occurrence of the composite endpoint of in-hospital mortality, bailout, clinical deterioration, and major bleeding. The mortality was remarkably low in this high-risk population at 1.9% in the FlowTriever arm, 28% was predicted, 29% in the context arm. This was not an RCT. We can't guarantee that all high-risk patients were captured. The treatment type was at the discretion of the treating physician, which may have introduced some selection bias. Follow-up was limited through discharge, but we do know that's the highest risk of mortality in the high-risk PE patient is during the index hospitalization. So the obvious implications, rather, is that large bore mechanical thrombectomy with FlowTriever likely reduced mortality by rapidly unloading the right ventricle, reversing the shock spiral, improving oxygenation, and basically care pathways that are established for STEMI and stroke would certainly benefit patients from high-risk PE, in particular cath lab teams that are accustomed to treating critically ill patients, that have access to advanced support therapies, is the ideal environment for these patients. I'd like to acknowledge Jim Horowitz, my other national co-PI. Jay Geary's site was the highest enrolling site in the FLAME study, and certainly thanks to all the other co-investigators and research coordinators. Thank you very much.
Josh?
Yep. Dr. Silver, first, congratulations to you and your colleagues for really advancing this field. I will say after years and years of very little happening, we now have a lot of things that are going on, and this is one of at least 4 significant clinical trials that should be completed in 2023. The field will be changing dramatically by next year. I think it's great that we're kicking it off with this, and I'm just going to ask a couple of questions about the way that patients got into the study. So do you have any insight into general patterns by which the investigators decided to enroll someone into the use of FlowTriever versus another pathway? And then second question, if you eliminated the people that got thrombolytic therapy from the other arm, did the outcomes look the same?
Great question. So the first question, there were 10 institutions that enrolled. The institutions were picked so that they had experienced FlowTriever operational doctors. It really came down to the physician team on call. So this is very real world, is what I want to emphasize. So when a high-risk PE patient came into whatever institution, most of these institutions have PERT programs. That was instituted, and then the best treatment for that individual was made based on the judgment call of those physicians. And I think that's what's critical, is the care pathway in this high-risk group really needs more focus and again, needs to be similar to STEMI, which is something we're all accustomed to. The other question I don't know the answer to. If we take out the systemic lytic patients and compare it to FlowTriever, we'll certainly get that for you for the publication.
I guess my last question is, do you think, well, I guess 2 parts. One, how does this technology get disseminated amongst providers who want to give it? Because obviously these were highly experienced individuals. And do you think that when you get a larger pool, a randomized trial would be possible?
Right, I think so. I think the big message here is that this large bore thrombectomy device works in patients with massive PE. I think we demonstrated that. And the generalizability will take time, but as we all teach each other, like would happen at my institution, then operators will get the experience to use this device. But it's certainly the perfect storm. The cath lab team has to know what's going on. The ER has to make the diagnosis quickly. It's that perfect storm of rapid diagnosis to the cath lab with the right operator. I do think it'll be generalizable over time, thanks to groups like the PERT Consortium and that sort of thing.
So maybe nobody else has this question, but I do, because I'm not in this field. So what other thrombectomy catheter would you have used before this? I mean, would that have been the control, or what?
That's a great question. So other thrombectomy catheters were allowed in the context arm.
But they weren't used.
They were used in the context arm,
Oh,
but
they were. Okay.
the context arm was any treatment other than FlowTriever, and then they could do anything they want. You could see, though, very little thrombectomy was done.
Right.
Very little thrombectomy was done. There are other devices on the shelf, and the field is going to get very busy. There's newer devices coming out. I don't know that I can say this based on the data, but based on my experience, this particular device is the best in class right now.
Okay. Go ahead.
One other question. Congratulations again on well-done study, and you are actually helping to close a very needed knowledge gap that exists in this area. How critical is the timing of the intervention?
It's a great question. I think it's very important. And once the decision is made that to diagnose it's a high-risk PE, then the doctor that receives the patient, typically the ER doctor or the ICU doctor, needs to activate the PERT team and get those doctors that are most experienced in seeing the patient. So time is critical. I think the one issue is the approach to this population, the high-risk PE patient, has become too algorithmic. And that's because the guidelines do say systemic lysis is the frontline treatment. But in centers that have a lot of experience with large bore thrombectomy, there's an aha moment that systemic lytics isn't necessarily at the front of the mind. It's called the interventionalist, get the cath lab team in and do a thrombectomy. And this group, you're well understanding of the risk of systemic lytics. It's not insignificant as we saw in the context group.